Now, welcome everyone to our second session in our 2021 virtual End Epilepsy Statewide Conference educational series. For those of you that are joining us, we appreciate your attendance. For those panelists that are on today to share their expertise and knowledge, we really appreciate you all being here as well. I'm going to go ahead and get started and talk a little bit about what sparked this program to begin with, how we've been involved in trying to handle the issue, and then I'm going to turn the stage over to the panelists for more information. So my name is Beth Stivers. I'm the Director of Education at the Epilepsy Foundation of Kentuckiana, and my job is, in addition to my cohort, David Pettit, is to basically in normal times is travel around the state and do different presentations for schools, hospitals, basically anybody that'll listen to us for about an hour, talk about epilepsy and seizures. We've also been involved with multiple minority outreach grants through the National Epilepsy Foundation and the CDC. So that's what this program stemmed from last year. So basically, welcome to hashtag Epilepsy Equity for African Americans in the Treatment of Epilepsy. Throughout 2020 and then throughout, it's continued, the conversation hasn't stopped regarding ending systemic racism in America. Unfortunately, with the police force and the educational system, we have noticed a disparity between African Americans and white individuals. However, that is not the only place where we are seeing discrimination, and unfortunately, it's also occurring in the American healthcare system. Basically, that is leading to individuals having an unequal access to quality medical care, and it's no different in just the treatment of epilepsy. So I will give you some statistics about epilepsy in African Americans. Basically, there are 375,000 African Americans living with epilepsy in the United States, and more than 20,000 African Americans are diagnosed each year, newly diagnosed each year. Unfortunately, African Americans are more likely to be diagnosed with epilepsy in an emergency room than white Americans, which definitely leads to a decreased quality of care, especially for follow-ups and medication issues. African Americans are more likely to develop epilepsy over a lifetime than white Americans, more likely to experience uncontrolled seizures than white Americans. And unfortunately, due to the disparity of treatment, medication issues, poverty issues, inequality issues, they're more likely to experience status epilepticus, which is a true medical emergency in which a seizure lasts 10 minutes or longer without stopping. And that's a huge problem. This should not be occurring. Discussions about ending systemic racism in the medical field or in general, we know can be pretty uncomfortable for most of us, as most of us would not consider ourselves to be racist. However, those of us who are white must remember that we are likely guilty of implicit racial bias, in which we hold on to just attitudes and stereotypes that affect our understanding, actions, and decisions in an unconscious manner. So by hosting this session, Epilepsy Equity for African Americans in the Treatment of Epilepsy today, the Epilepsy Foundation of Kentuckiana and our panelists are hoping to, we started the conversation earlier this year, and we're hoping to kind of continue that conversation to hopefully eradicate implicit bias in the treatment of epilepsy, to ensure that hashtag Epilepsy Equity for African Americans in all people throughout Kentucky, Southern Indiana, and our nation. So while we are having the conversation today about how to end this bias in the treatment of epilepsy, we also must remember this conversation is definitely not good enough. We're hoping that those of you that are on this call will take in this information and share it with others, because we do need to continue moving forward to make these necessary changes to current neurology and all medical practices to remove these biases throughout the nation and throughout the medical field. So just to give you an idea of what the Epilepsy Foundation has done recently to help with this problem, we had a program with the National Epilepsy Foundation and the CDC. We received a grant And the grant name was hashtag Epilepsy Equity for African Americans on Team Kentucky. And so for that, I'm just going to give you what we did. That grant ended earlier this year. However, we are pretty impressed with our reach of how many people that we were able to reach with the message. We had a PSA that we shared through the website, YouTube, and targeted Facebook campaigns. And we reached we had 224,625 impressions and 78,758 people were reached directly. We also had bus advertisements, and that advertisement, well, you can see pictures on the next slide. In Lexington and Louisville, which were our largest markets, we wanted to make the biggest impact for the money we were spending and the people we were reaching. And we had almost 2 million impressions with that campaign. We did the training program for healthcare professionals, which is the same program you're going to be seeing today, with about 40 participants around the nation, as well as we've had 44 watches on YouTube since then. We've held our virtual seizure first aid education certification training programs. We've been on, that has been ongoing. We do that twice a month, but specifically for this grant, we did 11 programs and had 347 individuals be certified for 2 years in seizure first aid and seizure recognition. And then we also wanted to try to get the hashtag epilepsy equity out there. And so we had over 12,000 impressions on our website, newsletters, and other social media posts. For our project partners, we had the University of Kentucky UK Healthcare Neuroscience Institute, Kentucky Neuroscience Institute, Campbellsville University, Kentucky School Nurses, Kentucky Office for Children with Special Healthcare Needs, Face It, the Face It movement against child abuse, and also Volunteers of America. So we tried as much as we could to get this message out. And so we thought for our conference today, our conference session, that repeating this session would be a great way to continue the conversation and get the message out to more people. So you can see on the left the bus ads that we had in Lexington and Louisville. And then I'm also going to show you briefly the PSA that we created that highlights this issue. And I will play that for you now. Maybe. Hold on.
Any one of us can have a seizure. 1 in 26 will be diagnosed with epilepsy in their lifetime. African Americans are more likely to develop epilepsy than white Americans. More than 20,000 new cases of epilepsy are diagnosed among African Americans each year. Learn the 3 simple steps of seizure first aid. Stay with someone when a seizure occurs. Keep them safe. Place them on their side without restraint.
So that's just an overview of the program that we did. And we are hoping to continue with this outreach program in the future. We are definitely not holding back with the message. So that's what the Epilepsy Foundation of Kentuckiana has been doing. But today, the panelists that are joining us today have done other work to try to get the word out. And I think the message that they have to give us is going to be something that, first of all, blows your mind. And second of all, I think will definitely open your eyes and make you more aware of this issue. So as we move forward with the presentation, please, I'll be moderating the chat box. So if you have any questions, please put that in the chat. We'll also hold a little Q&A session at the end if there are any questions for each panelist. So our panelists today are Dr. Meriem Bensalem-Owen, and she's the epileptologist and director of UK Healthcare at the Kentucky Neuroscience Institute's Comprehensive Epilepsy Center. Carey Ruiz, PhD, she's associate professor of sociology and justice studies and the director of diversity and community at Campbellsville University. Dr. Ima Ebong, she's an epileptologist at UK Healthcare Kentucky Neuroscience Institute and the founder of UK's Minority Education Development Program. Rachel Ward Mitchell, RN, she's the epilepsy nurse coordinator at the UK Healthcare Kentucky Neuroscience Institute. Regina Hamilton, PhD, she's the assistant professor of English and African American and Africana Studies at UK's epilepsy and a UK epilepsy patient. And then myself, and then Sonia Ferguson, MSW, she is our Director of Client Services at the Epilepsy Foundation of Kentuckiana. So I am going to stop sharing my screen, and then I'm going to introduce Dr. Bensalem-Owen. Just a second. Accidentally closed out the intro slide. Hold on just one moment. I apologize.
Otherwise, Beth, I'll be happy to introduce myself if
I can do it real quick. Actually, I'm going to let you introduce yourself because I just realized I cannot find it in a timely manner. So basically, our first panelist is Dr. Meriem Bensalem-Owen. I'm going to let her give you her credentials and where she studied, but she's also our board chair at the Epilepsy Foundation of Kentuckiana, and she has worked very closely with us over many years in helping bring patients to us, as well as helping us raise funds and awareness for the Epilepsy Foundation of Kentucky. And I apologize for the diversion, but I will let you take it away, and thank you so much.
No, this is perfect, Beth. Actually, because the highlight is not really me, it's really my colleagues. And I just wanted to note that we have a fabulous, group of panelists that are all women. Interestingly, I just realized that, and so just wanted to point that out. But thank you, Beth, again. So first, good afternoon, everyone, and thank you for joining us for this second session, as Beth mentioned, for this program. And so I am I'm a professor of neurology, and I'm the director of the epilepsy program at the University of Kentucky. I'm also the director of the Epilepsy Fellowship, which is the first one, the first ACGME accredited fellowship in the state of Kentucky. So we're very proud of that. I am the current secretary and treasurer of the National Association of Epilepsy Centers, and the current president of the Epilepsy Foundation of Kentuckiana. So it's just an honor to be serving in these positions. And I'm very, very thankful for the opportunity, and also that the Epilepsy Foundation, gave me, but also for the work they're doing to be the best advocates for our patients with epilepsy. What I would like to also say is that I would like to congratulate Beth and Deb for securing funds. There are just a handful of organizations, affiliates that received funding for this program nationwide. This grant was funded by the CDC and by the National Epilepsy Foundation. So it's just a great honor to be part of this program. And well, without further ado, I would like really to introduce the first speaker, and it is my pleasure to introduce Dr. Carey Ruiz, who is an associate professor of sociology for the Division of Social Science and the director of diversity and community at Campbellsville University. Dr. Ruiz teaches courses in sociology and specializes in social justice issues. She completed her PhD in sociology from the University of Kentucky in 2012 and completed her undergraduate and master's degree in sociology and women's studies from Western Kentucky University. Dr. Ruiz specializes in social inequality, specifically race and social class. In the past, her research interests have included public perceptions of welfare recipients, an evaluation of impoverished women's reproductive choices, best practices for teaching about race, and other controversial topics in the classroom. She has also a particular interest in the way in which perceptions and stereotypes are influenced by social structure, and how those perceptions motivate people into action. She has also collaborated with other researchers in the area of examining relationships between poverty and eugenics and human trafficking. In addition to conferences presented and publications in the area of race and poverty, Dr. Ruiz has led several university student groups discussions on race relations. She also served as panel discussant and led forum discussions on race and poverty in her community. So Dr. Ruiz will share a historical perspective of the roots of racism in healthcare. So Carey, please.
Thank you, Dr. Bensalem-Owen. I appreciate that introduction. That was very, very nice of you. And as Dr. Bensalem-Owen mentioned, I don't come from a medical background. So my portion of this conversation may seem a bit different than what most of you are accustomed to. But in my area and in many areas of social science and law, we focus on using an approach that is data driven. And that's always important because I think that's lost in the conversation, that using data, we try to seek to explain the way in which we order our society and our institutions and how that perpetuates inequality or how it benefits some over others. Even when individuals have good intentions or no prejudice. And so this approach goes beyond and debunks two very commonly held assumptions that people often have. And that's one, that race is biologically real. And so that's an important piece, I think, to this conversation this afternoon, is that there's no basis in the human genome to suggest subspecies of humans. So to say that race is something that is inherent to the human biological condition is not entirely accurate. And the second commonly held assumption that we debunk in using this particular perspective in social science is that racism is merely a matter of bad thinking and not something that has been woven into our cultural tapestry over time. So I wanted to spend a little bit of time this afternoon discussing medical policy and practices that have created a precedent of inequality, even when these practices were framed as meeting the common good, and even when women and or Black people and or Indigenous people endorsed these practices. So there has been a well-documented history of maltreatment of Black Americans at the hands of medical professionals in our US history. From J. Meriem Sims, who is the gynecologist, the famous gynecologist who invented the forceps, who practiced his techniques on female slaves, often without anesthesia, to the infamous Tuskegee syphilis experiment, which I'm sure you're all familiar with, where 28 patients died directly, 100 more were died from complications, and their families were infected. And even the diagnosis of epilepsy itself, which is interesting, was weaponized and ultimately used to create policy that went against the interests of Black and Indigenous women. So you have the case of 19-year-old Carey Buck, who was a white woman, but she was sexually assaulted. She became pregnant. After she gave birth, she was sterilized against her will. And this practice of forced sterilization ended up being upheld by the US Supreme Court in 1927, with Justice Oliver Wendell Holmes proclaiming 3 generations of imbeciles is enough. And of course, that affliction that she had was epilepsy. This paved the way for years of sterilization abuse against Black and Indigenous women, due in part because of that Supreme Court ruling, and then in a large part because of the popularity of another medically based movement that spread like a brush fire in the United States, and that was, of course, eugenics. Many academics across the nation supported the movement of better breeding, including W.D. Funkhauser. And if that name sounds familiar, because he is the man whom we named the Funkhauser Administration Building at UK. And even some of the Black academics who supported this use of eugenics. Charles S. Johnson, who was a sociologist and the first president of Fisk University, supported what he called eugenic discrimination against Black people. Even progressive movements, medical movements, progressive ideals such as the birth control movement ended up hitching its wagon to things like eugenics and discrimination in healthcare, particularly against Black people. Margaret Sanger, who is, the founder of this birth control movement in the United States, also created something, and again, pardon my language here, created something she called the Negro Project to assist Black women, in her argument, in getting reproductive health care that she believed they were being denied. But it went a little farther than that. And she was also assisted by yet another sociologist. And I'll bring this up just so you know I'm not just picking on healthcare providers. But she received assistance from W.E.B. Du Bois, who was another Black sociologist who counseled her on ways to make her language favorable, especially in Black churches, so they could push birth control and sterilization on Black women. She's quoted, and I want to forewarn some of the language that's pretty racist in this following quote, but she says, "The mass of Negroes, particularly in the South, still breed carelessly and disastrously, with the result that the increase among Negroes, even more than whites, is from the portion of population least fit and least able to rear children properly." So that was in 1939. So there was this definite racial undertone behind what was at the time something that was conceptualized as a legitimate science. Of course, as we move forward in US history, the popularity of things like eugenics waned post-World War II. In 1972, the American Journal of Public Health started highlighting some genocidal concerns and fears. Plus you had the 1973 lawsuit by the Southern Poverty Law Center on behalf of 12 and 14-year-old Minnie and Mary Alice Relf, who were sterilized against their will. This slowed the use of forced sterilization. But these racial disparities are still with us. For example, we see that recent studies suggest that 40% of medical students believe that, and this was from a 2012 study, believe that Black people have, quote, thicker skin, or that Black people are 22% less likely to receive pain treatment when they need it. Black women are 3 to 4 times more likely to die in childbirth than white women. There was the story of Serena Williams in 2018. She nearly died in childbirth because the docs did not originally listen to her when she was expressing some difficulty in breathing after she had given birth, after she'd had a cesarean. There are problematic teachings in medical school that still exist. Dr. Joia Creer-Perry of the National Birth Equity Collaborative tells about being taught in her medical school courses as late as the 1990s about 3 distinct races. And she also was told in her medical program that Black women and white women had different shaped pelvises. Then we've gone through this pandemic, which highlighted these disparities even further. According to the CDC, Black people are 3 times more likely to be hospitalized from COVID, they're twice as likely to die compared to their white counterparts. And in 2020, there was the tragic case of Dr. Susan Moore, who's African-American, who died of COVID after speaking publicly about the racist treatment that she received at the hands of her own colleagues. And she was a medical professional who knew the medical language to use. So what happens then when someone who doesn't have that same cultural capital encounters physicians and healthcare providers who might have that implicit bias, as Ms. Stivers mentioned earlier? It can be a very different story. So to conclude, it may be easy or tempting to think of these incidences as a one-off event. However, within the US historical context, they become part of a continued narrative for people who are Black or Indigenous or Latino, and it is something larger than just a few mere isolated incidents perpetuated by mean-spirited people. So one of the best things that I believe healthcare workers and healthcare providers can do is really to be aware of how this general structure of healthcare has been built around discrimination. Listen to your patients, take them seriously, believe them when they say they are experiencing discrimination, because hundreds of years of cultural precedent doesn't just disappear. You can be an advocate, you can call out bad science, you can check your colleagues when you hear them express wrong attitudes about their Black or Indigenous patients, because white people can and should speak out against racism. And also, and perhaps most importantly, recognize that it is racism and not race that is the driving force in many healthcare disparities between Black people and white people. Epilepsy is a biological condition. The disparities between the way in which your Black patients and white patients experience epilepsy, the way it affects their day-to-day lived experience, is not a biological condition. No. A good resource further to check out is the Joia Carey in the Lancet journal, Moving Toward Anti-Racist Praxis in Medicine, if anyone's interested in checking that out.
Thank you very much, Dr. Ruiz. That was a difficult, but I think a very, very interesting, to understand the background. And I know with your discussion, Dr. Ebong will share also some other situations, similar situations, but it's very disheartening. It's very upsetting, actually. I mean, I'm sure the audience felt this way. I mean, I had several times, goosebumps and felt my heart racing hearing these stories. And I don't know if anybody from the audience or the panel has any questions for you. We could take, of course, questions at the end, but if there are any nice and fresh questions or comments, please feel free either to put them in the chat or ask Dr. Ruiz before we move to our next speaker. And I think we can leave, since nothing is coming. I'm just checking my the chat box. I guess we will move. Thank you very much again. We will move to our next speaker, and it is my pleasure to introduce my colleague, Dr. Ima Ebong, who is an assistant professor of neurology at the University of Kentucky. She is also the director of diversity and inclusion for the Department of Neurology. She received her doctorate of medicine degree from UK. She completed both her residency in neurology and fellowship in clinical neurophysiology at Jackson Memorial Hospital in Miami, Florida. Dr. Ebong is a diplomat of the American Board of Psychiatry and Neurology and is a board certified from neurology, both neurology and clinical neurophysiology. Her interest in equity, diversity, and inclusion in medicine began as a medical student when she established the University of Kentucky Medical Education Development, UK Med, in 2010, actually. It is an annual recruitment program for prospective medical students from underrepresented backgrounds. She's an advocate for holistic training education, and she developed an anti-racism and social justice curriculum for neurology residents in our department. And she received for her work several awards. Dr. Ebong is a graduate of the American Academy of Neurology, or AAN, Diversity Leadership Program. She's a founding member of the AAN Underrepresented in Neurology section. And just last year, Dr. Ebong was selected to serve as a member of the AAN Specialty Commission on Racism, Inequity, and Social Justice. She's a member of the AAN Diversity Officers World Group and serves on several speaker panels at the national level. So in very few years after joining our department, she's been very active, very productive. And in 2020, Dr. Ebong was named one of 1,000 inspiring Black scientists in America, published by Cell Mentor and the Community of Scholars. And Dr. Ebong will be speaking about the medical aspect and the lack of equity in the treatment of epilepsy among African Americans. Dr. Ebong, the floor is yours.
Thank you so much, Dr. Bensalem-Owen, and good afternoon, everyone. It's a pleasure to be speaking with you all today. I'm going to go ahead and share my screen. Okay. Okay. So I don't have any disclosures. And today, briefly, we'll discuss how the neurology workforce deficit may contribute to neurological healthcare disparities among African American populations. Then briefly discuss the disparities in clinical and surgical management of epilepsy in the same population. I'll highlight briefly the history of mistrust and then the importance of outreach. So Before I get into the neurology workforce deficits, I want to give you all some data regarding the US Census. So this comes from 2019 census data, and this is the breakdown of race and ethnicity in the United States. So 61% of the US population is considered white, followed by 18% Hispanic or Latino, 12% African American, 5% Asian, and then 1%, well, less than 2%, because when this was rounded, it was 0%, but less than 2% Native American or Alaskan Native, Native Hawaiian, or Pacific Islander. And the rest are considered other, and these can be people who didn't select any race or people of multiple races are considered other. When we look at US physicians in general, we can see that there are certain populations that are underrepresented in medicine. And what that means is that compared to their numbers in the general population, their numbers are underrepresented or low. So for instance, white people make up about 50%, 56% of US physicians. And this is close to their population in the US, which is about 61%. Black or African Americans, however, make up only about 5% of all US physicians. As I stated in the prior slide, according to the 2019 census data, Black or African American people make up about 12% of the population. So they're considered underrepresented in medicine. Similarly, Hispanic or Latino people make up about 5.8% of all physicians, whereas in the general population, they were close to 18%. And again, Native American, Native Alaskan, Native Hawaiian, and Pacific Islanders, they made up less than 2% of the total US population you saw from the previous slide, but here they don't even make up 0.5% of all US physicians. When we look at the data for US neurologists, it's actually no better. So again, Black or African Americans remain underrepresented. Only about 3% of all US neurologists are African American or Black, and only about 7% are Hispanic or Latino. And again, looking at their numbers in the general population, they remain underrepresented. If you recall, again, Black or African American people make up about 12% of the US population, and Hispanic or Latino make up about 18%. And the same with Native American, Native Alaskan, Native Hawaiian, and Pacific Islanders, they're underrepresented in medicine as well, and in neurology as well. When we look at the geographic distribution of neurologists, again, the places in the United States where there are significant numbers of African Americans, we see fewer outpatient neurologists per capita. And the region with the most or the highest population of African Americans is the southeastern region of the United States. It's home to about 55% of the Black population of the entire US, but there are fewer outpatient neurologists per capita in this region compared to the Northeast, which has the most neurologists per capita. When you compare state to state, California has the largest minority population, but if you look, they only have about 4 neurologists per 100,000 people, and compare that to Massachusetts, which is less diverse and a more homogeneous population of people. They have more neurologists per capita, double that of California. So why is this important? We need a diverse physician workforce, but importantly, we need a diverse neurology physician workforce, or neurologist workforce. So there's one quote that I love from Meeks et al. That was published in 2018 from the AAMC. And it says, when healthcare providers have life experiences that more closely matches the experiences of their patients, patients tend to be more satisfied with their care and to adhere to medical advice. And this effect has been seen in studies addressing racial, ethnic, and sexual minority communities when the demographics of healthcare providers reflect those of underserved populations. So essentially, we may mitigate healthcare disparities if we have a more diverse physician workforce, and specifically mitigate neurological healthcare disparities, which includes epilepsy disparities, if we diversify our neurology physician workforce. So let's talk about briefly epilepsy disparities in African Americans. And I'm going to first kind of echo what Dr. Carey Ruiz said. We have to acknowledge racism. So the CDC has recognized that racism, not race, is a serious threat to public health. And Dr. Ruiz did such an excellent job explaining this to us earlier. And the disparities are due to racial prejudice that result to structural inequalities. So again, not the race of the person. Racism has negatively affected communities of color, particularly African American communities for centuries in this country, as well as Hispanic and Native American populations. And this disproportionately impacts social determinants of health. And just a reminder of the social determinants of health as characterized by the CDC. They include healthcare access and quality, neighborhood and the built environment, social and community context, economic stability, and then education, access, and the quality of education. And I also want to reiterate something that Ms. Beth Stivers talked about earlier in her introduction. And this was taken directly from the Epilepsy Foundation website. And the sources are here on the bottom right. But essentially, this is a summary of the epilepsy disparities that are seen in African Americans. African Americans are more likely to be diagnosed with epilepsy in an ER than white Americans. African Americans are more likely to develop epilepsy over a lifetime than their white American counterparts. And finally, they're likely to experience the medical emergency status epilepticus. And just to delve into this a little bit more, I wanted to show you all evidence from a paper that was published back in 2006 by Slavarsky et al. And the title of the paper is at the bottom, Racial and Ethnic Disparities in the Treatment of Epilepsy, What Do We Know? And some of the things we saw back in the 1980s, we still see the same thing 30 plus years later. So again, African Americans are more likely to be seen in the emergency department. And one study here showed that 79% of patients were Black, and of those, only 14% were receiving anti-seizure medications, and 57% had a subtherapeutic anti-seizure medication blood level. In terms of hospitalizations for epilepsy, this study back in 1995 showed that there were fewer whites than all other racial groups combined that were hospitalized for epilepsy. And then this other study in 1996 showed that for hospitalizations for epilepsy and compliance with treatment, 85% of those hospitalized for epilepsy were African American or Hispanic. And just like we saw in the 1981 study, in 2004, this study showed that African Americans visited the ER more for their neurological disorders, including epilepsy, more so than their non-Hispanic white counterparts. And we see that even in the pediatric population. This last study on the bottom was done in school-age children, and it showed that fewer Black students were receiving their anti-seizure medications compared to their white counterparts, with a p-value of less than 0.02, so it was statistically significant. We also see disparities in epilepsy surgery. So this one study by Borneo et al. In 2005 showed that African Americans were less likely than non-Hispanic whites to undergo epilepsy surgery. And this other study by Swartzrober et al. In 2003 showed that only half of African American participants said they would consider epilepsy surgery if they were eligible. And finally, the different study by Borneo, but in the same year, 2005, showed that African Americans were more likely than non-Hispanic whites to have a seizure recurrence after epilepsy surgery. So again, we see disparities not only in the medical management of epilepsy, but also in surgical management. We also see disparities in clinical trials. And clinical trials are very important in the medical field. Clinical trials are a way for us to test medications and also, sorry, something popped up on my screen. For us to test medications and also advance our field so that we can look for and come to conclusions about newer drugs, newer treatments, and newer ways to prevent diseases. So it's important, one, for clinical trials to have representation from all people, not just one homogeneous group of people. So African Americans historically are underrepresented in all clinical trials, and this is true also for epilepsy clinical trials. So participation in trials improves the health of everyone involved. But before we start talking about clinical trials, I think it's always important to address the history of mistrust due to experimentation and medical racism. This photo that you see here on the right is a photo from the National Archives of the Tuskegee syphilis experiment. And Dr. Ruiz again mentioned this in her introduction. It's not the only example of medical racism in this country, but it is widely known by many people. And so that's why it's almost always used as an example. We must enforce that clinical trials are closely monitored for safety and ethical treatment of participants, unlike what was seen in the Tuskegee syphilis experiment. We must also highlight the benefits of clinical trials, which are possible treatment for disease. Patients involved in clinical trials always receive expert care, and they have access to novel treatments before the general public. But at the same time, we have to be honest about potential risks of clinical trials, which include perhaps receiving placebo other than the drug and potential side effects. So again, just to briefly highlight the mistrust, and Dr. Ruiz talked about this in her talk earlier, but I just want to mention mistrust specifically in epilepsy. So in 2003, this paper was published, Patient Attitudes About Treatments for Intractable Epilepsy. This was a study of a group of participants from the Epilepsy Foundation in California, in one of the cities in California. And so some of these are the quotes that were taken directly from that paper. One person stated that even though all of the African-American participants were recruited from the Epilepsy Foundation and received the Epilepsy Foundation newsletter, only 3 of the 6 knew the type of epilepsy that they had. So only half of those African-American patients knew what type of epilepsy they had. One participant who was interested in joining the Epilepsy Foundation voiced her discomfort regarding participating in the group. And her quote directly was, "Not being negative or anything, but they were older and white and I was Black." So again, feeling uncomfortable in that environment led her not to participate in the group, even though she really wanted to participate in the group. And then finally, African Americans have described just in general distrust in the healthcare providers that they had. So these are real quotes from this paper, and there are a lot more, and I would recommend if you wanted to read some more to find this article, again, Patient Attitudes About Treatments for Intractable Epilepsy, published in Epilepsy Behavior in 2003. And finally, I do want to highlight this book, Medical Apartheid by Harriet Washington. We're actually reading it as a department this entire year during our book club. We have the second part of the book club coming up pretty soon. And the reason why I would recommend this book is, as I stated earlier, the Tuskegee syphilis experiment is not the only example of medical racism, but it's the most widely and well-known. Dr. Ruiz highlighted the eugenics movement. She highlighted other examples of medical racism in this country, and this book also delves deep into that, from slavery up to now, actually. So I would highly recommend purchasing this book. Very well written, and it can be understood by anyone, not just medical professionals. It's written in such a way that anyone can understand the book and really appreciate where the medical field has come from over the last few centuries. And before I end, I wanted to leave this quote by Dr. Brett Casella, who's the chair of neurology at the University of Cincinnati, and also Dr. Louis Morgenstern, who is at the University of Michigan, also a neurologist. And they were talking about stroke disparities, but I think that this quote can be applied to all medical disparities, including epilepsy. And the quote is, "It is of paramount importance to recognize that inefficiencies and inequalities in the healthcare system drive these issues." So these issues are disparities. And that we meaning those in this healthcare field, should not blame the victims, but rather look in the mirror for solutions. So we are the ones that need to come up with the solutions for these healthcare disparities. And in the interest of time, I can't go into all possible solutions, but one thing I wanted to talk about, because this is the Epilepsy Foundation, I wanted to highlight outreach. So one of the ways that we can mitigate healthcare disparities is outreach into those communities that are affected. So things that can be done is to develop a budget to perform outreach. And this comes directly from the Epilepsy Foundation website. They are dedicated to African American outreach at the national level, as well as at the regional level here at the Epilepsy Foundation of Kentuckiana. There should be standard practice and culturally competent recruitment strategies, especially for clinical trials. If you want to go out and recruit patients for clinical trials, particularly African American patients, you have to go out into the community and be culturally competent. And you have to partner with the community. And I just put one example here, the Balm in Gilead, which is a national organization that aims to prevent diseases and improve health in the African American communities in this country. I was honored last year to be a participant in their conference. And every year they have this national conference and they talk about overall health for African Americans. And they have sessions dedicated specifically for neurology. And there were a few neurologists on the panel discussing everything from epilepsy to dementia to strokes. And so those are avenues that people can use to reach out to the specific community. So I just want to say thank you for allowing me this opportunity and to leave you with one of my favorite quotes by the Reverend Dr. Martin Luther King Jr. "Of all forms of inequality, injustice in health is the most shocking and the most inhumane." So thank you very much.
Thank you, Dr. Ebong, and thanks for finishing with this beautiful and so true quote. And unfortunately, it is true. It's a very cruel way. So, and thank you for highlighting the roots of mistrust in healthcare by African American epilepsy patients, and also for highlighting the importance and need for outreach. So thank you. And I know we had an exchange of emails today between Beth, Deb, and you regarding outreach and grants and how we can do better. So hopefully we can incorporate that. So it's very timely. So that was perfect. Thank you so much again. I don't know if we have any questions from the audience or in the chat box, direct questions. I know we had comments about willingness to join the book club. So would it be open to others, non-neurology members?
Yes, definitely. So we divided the book into quarters. So we already read the first 4 chapters. So the next book club, I can send the link out. It'll be in a few weeks. We're just trying to lock in the date with the holiday coming up. It's oh yes, you'll be allowed, Dr. Hamilton. With the holiday coming up, we're still trying to lock in the date, but we'll read the second quarter of the book. And so the book club will take the whole academic year. So we'll end in sometime in May 2022. And even the first session, we had people from College of Medicine who weren't in neurology join us for the book club. So I will send the link out as soon as we lock the date.
That's wonderful. Thank you so much, Dr. Ebong. And I think Dr. Ruiz already read the book. She commented that it is excellent. Thank you. So I will introduce Dr. Regina Hamilton then. You're next. Perfect. So Dr. Hamilton is an assistant professor in the English department and African American and Africana Studies program at the University of Kentucky. Her primary fields of study are the 20th and 21st century African American literature and women's and gender studies. Dr. Hamilton has been diagnosed with epilepsy since 2013, and she will be sharing with us her experience and perspective as an African American patient with epilepsy. So thank you very much, Dr. Hamilton, for sharing, because this is a very personal experience or very personal experiences. So thank you very much for opening up and sharing these with us.
No problem. Thank you for having me. This is the second time I've kind of shared my story. It's often a little strange to come as just like a firsthand respondent instead of a scholar, but I do think that my background in race studies and African-American studies has helped me in some ways make sense of my own experiences as an epilepsy patient. Dr. Ebong is actually my neurologist. I love her, she's the best. But she's like my fourth neurologist over the past almost decade. So I've had some experiences that weren't so great. As you said, Dr. Bensalem-Owen, I became an epileptic in 2013. It was my second year of my PhD program. I hadn't, that was the year where everything kind of took off. And so I had not been eating, had not really been sleeping much. And basically in the middle of the night, I had some severe arm pain, and called a friend who took me to the emergency room. So I was one of those seemingly very many African Americans who are diagnosed with epilepsy in the emergency room. And I had no idea. I'd never had any history of seizures. I had never any history of brain damage or anything related. So I was kind of overwhelmed and shocked by that diagnosis. And what I needed in that moment was support, and I did not get it. My neurologist at the time that I saw after my hospital stay didn't really, I think he, just kind of like handed me a pamphlet that said, this is what epilepsy is, and threw me on Keppra, levetiracetam, I think is the name for it, and just kind of like, shipped me out the door, right? I didn't see him again for months, right? And what I found out later was that I had continued to have seizures because that medication was not really stopping my breakthrough seizures. And I continued to have them unbeknownst to me until I had one bad enough to like total my car while I was driving. And so, and I didn't trust him. He never gave me any information. I was a PhD student, still operating from a considerable place of privilege myself, but I never got any information about, I didn't even know what type of epilepsy I had. Dr. Ebong just said that about how many African-American patients that were signing up for that clinical study just didn't even know what kind of epilepsy they had. I didn't know at all. And it would be years until I found out, right? Some questions about my condition I have not had answered until Dr. Ebong became my neurologist in 2019. And at that point, I'd been an epileptic for like 6 years by the time we met the first time. And I came to meet her with a list of questions, like, I've always wanted to ask this, but didn't feel comfortable asking, or I asked this and my neurologist at the time wouldn't answer the question. I remember one time I asked a neurologist, are there any, this is a wild question, but are there any, recreational drugs I should stay away from, right? And her response was, this other neurologist, her response was, is that why you ended up having seizures in the first place? Was that you were doing drugs? And I was like, no, I'm a researcher and I'm seeking information, right? I am seeking ways to understand my condition, and so that was a question that didn't get answered, right? it's been a trying experience over the years. And as I've gone deeper and deeper into my education, it has the things that I've learned about white supremacy, about the sort of the root of white supremacy is sort of hollowing out the humanity of Black people, and how that affects every component of Black lives, right? And I feel very much to be the truth that a lot of my neurologists didn't see me as a person. They didn't feel the need to give me deeper information. They didn't empathize with me as a young Black woman, already extraordinarily stressed in a doctoral program, and finding out suddenly that the one organ that directs my career is one that I can't trust anymore, right? I also had a neurologist who didn't want to allow me to try other medications when we found out that campylobacter wasn't working. Her suggestion of the next course of study was that I should have surgery, and a rather intense surgery too. I mean, I think her belief was that, my entire temporal lobe should be removed. And we had only tried one medication that was just sort of like given to me without any, there was no conversation, there was no, there was no real treatment plan, right? These are things that I didn't receive until I had neurologists like Dr. Ebong. And so, I was walking out of the Turfland Clinic after getting blood drawn, and I saw an advertisement for African-American support group for people living with epilepsy. And it was like shocking to me. Dr. Ebong and I had talked about that actually, I think last year, but just to see that that was something that was being publicized and made available to people like me gave me great joy and hope for a better future for those who will be diagnosed with epilepsy. I don't have too much more. I'm just happy to be here and share my story. And of course, there are more things that happen, but I just wanted to throw those particular experiences on the table. And I'll just stop there.
Thank you so much, Dr. Hamilton, for sharing and being with us and sharing. I know the last time we had another epilepsy patient, so and this time you're the only one. So I think you're very brave and courageous to come forward and really sharing this experience. Thank you so much again. Dr. Hamilton, may I ask you, how did you find out about Dr. Ebong? I mean, I don't know if you were seen before in our group, in our epilepsy group, which has expanded considerably, but how that happened?
So once I was hired by UK and got this amazing insurance, I went on a hunt for Black female doctors. I have all Black female doctors. My gynecologist, my neurologist, my PCP, everybody is a Black woman. The only one who's not is my dermatologist. And that's only because I could not find one. And so I think that, but I just hope that I hope that would make a difference, right, in my treatment overall, but also in my treatment for my disease, but also in my treatment, personal, how they treated me as another human being that needs medical treatment, right? And it has, shout out Dr. Ebong, you're the best. But yeah, I mean, because as a person seeking medical treatment, you don't have a lot of options, but you also don't, there's not a lot you can do to make sure a person treats you like a human. The best you can do is try to find somebody that has experiences that are similar to yours, hopefully, and who can understand why you might have certain misgivings and be willing to explain things to you. And so that's the best you can do is I guess I'll find somebody that's kind of like myself, hopefully. So that worked out though this time. but it's a step I wish patients didn't have to take,
Sure.
right? You know,
Mhm.
so.
Could I add something about, because I'll never forget how you found me. Like, I mean, you're right, you sought me out, but it was the way you sought me out on Twitter.
Oh yeah, that's right.
She DM'd me on Twitter when she was moving to Kentucky from when you were moving. It was about a month or so before you came in, and we got her right in. I was just, I was kind of new to social media then too in 2019, so I was like, oh wow. A patient reached out, and I was like, yeah, we'll get you seen, and that was the end of it.
Yeah,
but it just shows
but it's been a privilege
too, because
yeah.
Like you said, seeing that representation, seeing Black doctors on social media, even for me, seeing other physicians, other neurologists who I didn't know in the field and can bounce ideas off of, who are African American. And we have this community now because of social media. We have a Black neurologist Facebook group, and there are lots of us on social media trying to advocate not only for our patients, but also for future neurologists. I talked about the neurology workforce. We want to encourage more African Americans to pursue the field so that we can treat the patients that need us. So it just shows the power. I just wanted to just talk about the power of social media as well.
Definitely. And for my other doctors, I definitely will find if you're a UKY employee, I will find your UKY email address and email you saying, hey, I'm looking for this kind of doctor, are you taking new patients, all these kind of things. But I also understand that is an extraordinary privilege, right? Even being like a public facing academic and having public facing social media accounts that I could reach out on Twitter to a person like Dr. Ebong, right? And felt like maybe she would answer back, right? That's an extraordinary privilege that most patients won't have. And
kudos to you for being your own advocate, and I think the best advocate. I think one of the issues is for people who can't even, wouldn't even know where to start, or where, if it is right or not, what's happening to them. And I think with these, terrible experiences, people sometimes just want to put them aside. It's kind of very traumatic. They don't want to speak about them. Some of them are very vocal about it, but some of them is like, I don't want to even get there. Just this week, I had one of my patients who has a disability, but I asked his parents, and they're African Americans. I said, we have this program, would you like to join, or at least, participate and share your experience with your son being an epilepsy patient who has an intellectual disability in addition. And I even asked, how was your experience at UK? And it was like, well, no, everything was happy. She was happy and everything was great, the mom at least. But she said, in Georgia, we had a terrible experience. And she was like pretty much said, I don't want to even speak about it. Didn't even want to share that experience didn't want to relive that experience. Some patients, will share it. It's kind of cathartic for them, but she just didn't want to even get there. It must have been very traumatic. They had other plans for today, otherwise they would have joined. Lovely, lovely family. But thank you so much, Dr. Hamilton. Thank you so much for sharing that. I don't know if there are any questions for Dr. Hamilton or any of the panelists who have already spoken. Otherwise, we can move to our next speaker. Dr. Ruiz, did you have any questions? I don't know, you popped for a second there. No, okay. Very good. So now I will introduce Rachel, Miss Rachel Ward Mitchell. So it's my pleasure to introduce Rachel, who has worked as a nurse at UK since 2004. I've worked with Rachel very closely. I mean, I think we're, beyond having a professional experience or work relationship, I mean, Rachel is a dear friend. So she spent 7 years working in the epilepsy monitoring unit. And in 2011, actually, after I took over the program directorship position, I invited her to join me on the other side. So from the epilepsy monitoring unit to to oversee and coordinate the program with me. So she shifted her role at that time and became our nurse resource coordinator. She has done an outstanding job since. She is a tireless advocate for our epilepsy patients. I don't know where she gets her energy, but she knows everyone, every single patient we have. And our group has expanded now to 10 epilepsy doctors, but she knows everyone. She assists patients through first diagnosis, ongoing treatment, clinic visits, hospital stays, diagnostic testing, surgery, medication side effects, psychosocial aspects associated with epilepsy. What's remarkable about Rachel is that every single patient knows about Rachel. They may not remember the name of their epilepsy doctor, but they know Rachel. So she works closely with the Epilepsy Foundation of Kentuckiana to advocate for epilepsy patients, educate, and also works with, has helped develop the Central Kentucky Epilepsy Support Network, and she will tell us about the resources that we offer in our program, but also resources offered by the network. So Rachel?
Okay, thank you. Thank you so much. I can't imagine doing anything else. I listened to Dr. Hamilton talking about not understanding her epilepsy. And I think it is not uncommon at all for people to not understand their epilepsy, even after decades of having it. And sometimes after years of treatment, they get to me somehow, maybe they've moved to UK, and I explain their epilepsy, and they say, you know, that no one has ever taken the time to do that. You know, that's really common to not really understand that. I think that when people are diagnosed for the first time, it's so overwhelming that probably even if somebody explained it to them, they may not actually be able to hold on to all that information. And I observe discrimination on a daily basis. I get calls and emails and texts about situations of discrimination based on gender, race, culture, definitely language, in addition to cognitive deficits or other disabilities and epilepsy. I also see a lot of people diagnosed with epilepsy not knowing another person like them or with their epilepsy type that might be able to kind of walk them through. So as an epilepsy nurse, my first priority is my patients and their families secondarily. And I'm an ear to listen to them. I am a shoulder to cry on. I am a heart to wrap them up in, and I really hold their hands through the whole, process and make sure that they get to a better place. I actually, while we were talking, I tried to do a search to see how many African-American Black nurses are in the United States, and the number I came up with was 9.9% of nurses identify as African-American. And we all know that representation matters. So I think, from a nursing perspective, it gave me some pause, and I'm sort of picking up some things, and I would really like to see us have a little bit better representation from the nursing perspective as well. So I am charged with sharing some of the resources that we have here at UK. Let me see if I can share my screen. I'm using my son's laptop today. Yes. And so if somebody could confirm you can actually see my screen, that would be great.
Yes, Rachel, we can see it.
Perfect. Okay, so here's a photograph of our epilepsy team, and this is not our entire team. Our team consists of so many more people, nurses that work on the units, on adult and pediatric, our EEG technicians. This is about, I don't know, maybe a quarter of our team, if even that. We do have a comprehensive epilepsy program and do provide a lot of advocacy. You can see right here, so many members of our team are involved in advocating for our patients and better epilepsy care. Our team of nurses on the adult EMU kind of went around and involved a lot of disciplines in our hospital, and took photographs. And this is for our virtual, the Epilepsy Foundation virtual walk. And so we were sharing epilepsy awareness here. This is our EMU staff, and there's Dr. Ebong and some of our staff up on the EMU. We do have a really great team of people who are dedicated to improving lives for people with epilepsy and their families. I have spent a lot of time developing networks of patients and families to connect for support. I facilitate a monthly support group. It's the first Tuesday of every month. And this is open to any adult who would like to attend, whether they have epilepsy, they have a family member with epilepsy, they're a caregiver for someone with epilepsy. And, we have sort of a core group of people that attend, and then we also have sort of some people that come and go. And I'd really like to involve more people. So I'm looking at some different ways to get people involved in different activities. So we do have in-person normally when we don't have a pandemic, in-person meetings, but since since the pandemic started, we moved to virtual, and I have added some additional meetings when I felt like we were really seeing a lot of people struggling with isolation, and which is not uncommon for people with epilepsy. They may not be able to drive, they may have a hard time getting out and being in a group of people for various reasons. So we've been doing it over Zoom, and I've been trying to also do some educational offerings as well. So this is open to anyone affected by epilepsy. It's RN supported. And of course, I'd love to see more of that and a more diverse representation with that group. I do some periodic special interest groups, as I said. So sometimes I'll do an educational session for epilepsy surgery, pediatric epilepsy, epilepsy 101, these types of things. And these can all be found on the website. So I sort of link together this support group at UK with our Central Kentucky Epilepsy Support Network. And this is a group that I worked with some families to develop. And so the purpose of this group is really to have more outside of the medical institution support. So there are a lot of families and some mentoring that goes on behind the scenes. And when people contact us and say that, their daughter was just diagnosed, I can connect them with people who may be able to kind of walk them through as well, just as a community mentor. We do social events when we can. We do have a Facebook page and a Twitter page, although full disclosure, I really struggle with Twitter, though I do my best. I put out a monthly newsletter, and we do have a mailing list, which is available there. And we've just recently started our community book club. And so we just finished our first book and had a couple weeks ago, had our first book club meeting. So as we add members, what we'll do, everyone throws a couple of titles into the pot, and we'll take turns selecting a book from the list of books. And it's, I have been in another book club for many, many years, and I find it a really nice way to connect with people. And even if we don't talk about epilepsy, I think it makes people feel like they belong to a family. And I think that's really important for people. And we've done a lot of fun events. We do have annual epilepsy education, we've had a strong partnership with Epilepsy Foundation of Kentuckiana, so thankful for them. And we, we want to be a part of their mission, so I'm here to support them, and I know that they are here to support us and our patients, and that's really important partnership for us. And that ends my very simple slideshow. And I'm glad for the opportunity to talk. And, I work for UK, but my job is for patients and people struggling with epilepsy. So you don't have to be a patient at the University of Kentucky to reach out to me for support. Okay.
Yeah. Thank you so much. Thank you so much, Rachel, for the work you do on a daily basis, and also for highlighting what we offer at UK, but also with the network that you helped develop. I have a question regarding the book club. What was the first book chosen for the book club?
The first book chosen was Harry's Trees, and the only prerequisite for the book is that it has to have some uplifting theme. So at the end of the book, we all want to feel good.
Very nice. I like that. That's what I do when I choose my movies. I want a happy ending. Yeah. Very good. No, but I think one point that's very important, I like, that you mentioned that in the healthcare system, we need to have better representation. We speak a lot about the doctors and the physicians and the providers, but also in terms of staffing, nursing, EEG technologists. And I'm very proud of our group. We have a very diverse group, EEG technologist group, but also faculty, epilepsy, the epilepsy group. But thanks for highlighting that, and also sharing the number, which is about 10%, which is very low. Actually, I didn't expect that. So I think it's nice to hear about these numbers. It puts everything into perspective. The other thing I think that I really liked what you mentioned is a sense of community. I think the diagnosis of epilepsy is already very scary. People are distraught with that diagnosis. And I think being in the category of an underrepresented group makes it even scarier, because you don't find anybody else with your same condition. So I think a sense of community is very important, and thanks for offering that. I don't know if we have any questions, comments. I think in the chat, I don't know if I'm seeing, trying to open the chat. Thanks, Deb, for the kind words regarding Rachel. Very good. And I think, yeah, if you could share, and I know you mentioned you're not on Twitter as active. I think you're doing a great job. We try to tag you to make sure, we highlight the work you do. And I think, the Epilepsy Foundation is already actually advertising or putting on their platform, social media platform, the events that you're offering with the support group. And thanks again for taking care of all patients. It doesn't matter. They don't have to be UK patients, because it's not about us, it's about the patients. So thank you. Oh, great. The boost. Yeah, thanks, Dr. Hamilton. We need to do a task force, a social media task force, subgroup. Excellent. That'll be wonderful. Very good. I would like to introduce our next speaker, Mrs. Sonia Ferguson, who is a new staff member of the Epilepsy Foundation of Kentuckiana, and a much needed one. She received her bachelor's degree in family and consumer science at Western Kentucky University. Mrs. Ferguson then married, speaking about good stories, her middle school sweetheart. They had a son, and then she went back to school to obtain her graduate degree in social work from Spalding University. She has over 15 years of experience working with children, families from disadvantaged backgrounds who struggle with different challenges and disabilities. Mrs. Ferguson also has over 5 years of experience utilizing trauma-informed care with clients, working with addiction and residential services. She is passionate about working with diverse populations to make a difference in people's lives. And Mrs. Ferguson will share information about the Epilepsy Foundation of Kentuckiana advocacy work, as well as the direct client services programs offered by the organization. Thank you, Mrs. Ferguson, for joining us and sharing all these resources.
Thank you so much, and thank you for the warm welcome. Hello, everyone. It's a pleasure to be a part of this today. I will share really quickly. So not only is it an honor to be a part of this foundation and work as the Director of Client Services, but I actually have, as she mentioned, a son. He is 6 years old, and he actually has epilepsy as well. And he was diagnosed last year in December, which was a very scary time for me and my husband and family, because we went a long time without even realizing what was going on with him. And being a part of a family who has no history of epilepsy, it was very scary. So I shared that with you all because not only do I take my job very seriously and I'm enjoying it, but it's very personal as well. I want to make sure that everyone who has or is suffering from epilepsy is supported, who has those additional resources that they may or may not have, because I know when my son was diagnosed, we had no clue about the foundation at all, which was alarming to me, because I was like, well, if my family didn't know, how many other people possibly don't know about this foundation? So yeah, so we are just very blessed that we have found the foundation. I'm so happy that I'm able to not only work, but actually advocate for my clients that we serve and my son, and just to get all of those resources and information out to the public. As far as the foundation here in Louisville, we have a lot of different direct services that we provide for our families and individuals that have been impacted with epilepsy. Some of those different services include working in school systems, as far as making sure that children have their seizure action plans, making sure that students in all facilities in the school system are aware of what it is and how to use one. And that is also something that I didn't know about until I worked at the foundation, because I was able to implement that in the school with my son. So for an example, if there is a teacher that's not there for the day, if it's a substitute, everybody working in classrooms and anybody in the school needs to be aware that if there's a situation or occurrence that happens with a child or anyone, that they know what type of action plan to follow and how to assist that individual or those children. So that's something that's very important, having IEPs or 504 plans for children in the school system, making sure that there are the appropriate modifications and different pathways for children to make sure that they are having their medical needs taken care of in school and academically being able to stay on track as well. A typical day at the foundation for me, as far as in my work, I may get phone calls with questions about insurance, or may needing just assistance with anything from a helmet to making sure that maybe medication can be taken care of or accommodated if for some reason they don't have those resources. So it's really just dependent on individuals and what they are needing in that moment, to making sure that their health is first, and that they're being treated fairly at work, or that if they have any type of issues, that they know who to reach out to and who to call. Some different programs that we offer at the foundation and different trainings. I know that there are different trainings for kids in the school system that can be an assistance in the classrooms and in the school to have those age-appropriate conversations for kids who have epilepsy, because I know those type of conversations can be hard at times for them to understand. We provide different first aid trainings online, which is extremely helpful, because if you are not trained in seizure first aid, then you can go to our website, and that is available for you to be able to take and be able to have that access, to be able to have those skills and knowledge about epilepsy and how it affects other people, and just making sure that, you know, that you're always educated in that area when you need that type of material. There's an epilepsy one-on-one training, again, just to make sure that people are understanding how people are impacted with seizures and how that may be a distress in someone's life, and just making sure that people have those tools to understand how to handle those situations. So again, as a social worker at the foundation, it's just really my job to make sure that when phone calls come in, that I'm able to handle them appropriately, to be able to reach out to people like you all who are phenomenal in the expertise of epilepsy, and just having resources for people to be able to understand and thrive. And again, just be in a community. I'll also mention this week, I participated in a panel of young adults who have children that have, and adults who have epilepsy. That was wonderful, a wonderful platform for people to come together and be able to speak about their experience, to explain different things that they have been able to accomplish, and even some things that they still may struggle in. And again, it's just a wonderful community to be able to just discuss with other people that look like you, or they may have the same conditions, of, you know, what I can do to help myself if I'm experiencing a problem, or where I can go if I'm having an issue, maybe finding employment, you know, just any type of concerns that may be troubling to somebody impacted with epilepsy. So that's kind of my overview. Does anybody have any questions or anything?
Thank you so much, Mrs. Ferguson. This is amazing. I can't tell you how happy I am for the foundation, for our patients, that you joined the foundation. And I think with your experience with having a child with epilepsy, I think, you know, I think it just brings a different dimension. And I think you can easily connect with patients. I'm pretty sure they feel that way. Is that right? Is it something you share with them?
Yeah, absolutely. When people do call, it just depends on, you know, the person in the conversation. You kind of can get a feel and read on when people call. But I have noticed that when in sharing my story with certain individuals and families, it's almost like you can hear it over their voice, just like a calming, just that somebody understands what we're going through, and somebody has an idea of why we are stressed out about another medication or another treatment, another MRI. And I can absolutely understand. And it's very rewarding to be able to not only be able to be an assistance, but just to be an ear to listen. Some people just need for you to just to listen sometimes. Mm-hmm. And that's the joy in this position, is just being able to not only listen, but also be able to provide resources that I possibly didn't even know about until coming into this position. Or if I did, being able to share that as well.
Sure. No, thank you. Thank you. Thank you so much for the work you do.
Thank you.
I don't know if yes, we're thrilled to have Sonia. Absolutely. Absolutely.
Thank you. And I also want to mention that the team has been